That's right. They made a sixth one.
Okay, that was maybe unnecessarily dramatic. Anyway, welcome to acute respiratory distress syndrome. In this sketch, we'll help you understand this frequent archenemy of ICU patients and medical students alike. We'll still go through the tried and true SOAP format here, but this one will be a little different because patients with ARDS are sick. Before we dive into the clinical presentation of ARDS, let's start off with some basics to get you situated. And by situated, I mean in line for Ards NATO, the ride. It's so hot right now. ARDS is a clinical syndrome of diffuse inflammatory lung injury leading to increased alveolar capillary permeability. At Sketchy, if you see fire, think inflammation. See those leaky red pipes over there? That's to help you remember that the super permeable capillaries in ARDS leak fluid and inflammatory mediators into the alveoli. This causes alveolar collapse, diffuse alveolar damage, and pulmonary edema, represented by those wet white life vests worn by the kids waiting in line. Really, kids? You still want to ride this ride? Okay. As a result of that pulmonary edema, gas exchange is impaired due to ventilation perfusion, or VQ, mismatch, just like the mismatched sizes of the V and Q on that sign up there. Additionally, lung compliance is decreased due to alveolar collapse and pulmonary edema, and pulmonary hypertension develops from hypoxic vasoconstriction and destruction of lung parenchyma. At Sketchy, pulmonary hypertension is represented by our recurring symbol, the stretched red net. This time catching that overly excited kid who leaned just a bit too far over that railing. And that's why guardrails exist, Braden. You're always learning stuff the hard way. ARDS is just the visible clinical outcome of a variety of different inflammatory insults. More than 60 different causes of ARDS have been identified over the years, but thankfully, you only need to know a few of the big ones, which we'll review in a moment. Because so many patients who develop ARDS are already super sick, you might not have much of a history to work with. That said, there's usually a characteristic pattern that can clue you in. Oh no. Breathing's about to be the least of your worries, underwater kid. Watch out for that self-aware animatronic shark. Man, I hate those. This underwater kid is presenting like most ARDS patients, with acutely progressively worsening dyspnea, which quickly evolves into full-blown respiratory failure, requiring intubation and mechanical ventilation, represented by that breathing hose that the employee's trying to rescue the guy with. Ooh, acute dyspnea. How specific. I know, it's not much to go from, but that's why you have to take the clinical context of the patient into account. By definition, ARDS develops less than 1 week and typically within 72 hours of an inciting event and progresses rapidly from there. Speaking of inciting events, let's cover the most common ones you should know. And for that, we're moving on to the trolley tour part of the ride. Sepsis is the most common cause of ARDS. That's why the kid in the trolley above that septic sewer is holding our recurring Sketchy symbol, the number 1 foam finger. Sepsis should be the first thing on your mind whenever ARDS features develop in a patient with a fever and a history of recent infection such as pneumonia or pyelonephritis. Ugh, have you ever tasted nasty theme park lake water? I'd be coughing my guts out too, kid. That whole mishigas represents the next most common cause of ARDS after sepsis, aspiration of gastric contents. ARDS will develop in up to 1/3 of hospitalized patients with an episode of gastric aspiration, which is why you'll hear your attending constantly harping on aspiration precautions on the wards. The vast majority of ARDS occurs in hospitalized patients, but that doesn't mean outpatients can't get it as well. Of the ARDS cases that occur outside of the hospital, the majority of them are precipitated by community-acquired pneumonia. At Sketchy, pneumonia is represented by our recurring symbol, the rusty chest plate, this time on that deep sea diver. But he's glad he's not down there in that water. Don't forget about trauma. We're not talking a simple broken arm here. These patients are the ones wheeled into the trauma bay looking bad. Severe trauma, such as pulmonary contusion, flail chest, and fat emboli are common precipitants of ARDS. See those flotation devices that look suspiciously like blood bags? These patients often receive massive transfusions of packed red blood cells, which is a risk factor for ARDS in itself. That said, you don't have to receive more than 15 units of blood to get ARDS. Transfusion of even 1 unit of plasma-containing blood product can sometimes cause ARDS. This phenomenon is called transfusion-related acute lung injury, or TRALI, and it's most commonly associated with transfusion of fresh frozen plasma. Notice the shape of that sea sponge sitting by the water there? Looks kind of like a pancreas, doesn't it? If you said no, well, you're just mean. But my feelings aren't hurt. Anyways, one medical condition that's often linked to ARDS is acute pancreatitis. Pancreatitis is a massively inflammatory process after all, so it makes sense. For more details on the presentation of acute pancreatitis, check out our sketch dedicated to it in the GI unit. There are many more causes of ARDS, such as near drowning, drug overdose, intracranial hypertension, and cardiopulmonary bypass, but these are much less common compared to the big ones we just mentioned. Interestingly, patients with alcoholism appear to have an increased risk of ARDS from other causes, for reasons that are not yet fully understood. Oh, that's why that guy's so happy. And seemingly unaware of what's happening down there in the water. So, your patient's got the right clinical setup for ARDS. Let's take a look at objective findings you should be looking for to help you make the diagnosis. First, look at oxygenation. Hypoxemia refractory to oxygen therapy is one of the defining characteristics of ARDS. At Sketchy, our recurring symbol for hypoxemia is the blue-faced scuba diver reaching in vain for his oxygen tank. Hypoxemia is also how we stratify ARDS into different levels of severity. Specifically, we use the PaO2 to FiO2 ratio, which is found by dividing the patient's arterial partial pressure of oxygen by their inspired fraction of oxygen. See how the PA and Fi are bolded on that sign that says passengers must be fit to ride? Fit to be eaten is more like it. Anyways, calculating the PF ratio assumes your patient is intubated and mechanically ventilated, which, if they have ARDS, is most likely the case. Mild ARDS is characterized by a PaO2 to FiO2 ratio less than 300. For comparison, a normal person breathing room air has a PaO2 to FiO2 ratio greater than 400. When the ratio drops below 200, you're in moderate ARDS territory. Finally, a PaO2 to FiO2 ratio below 100 is considered severe ARDS. To give you some perspective on how sick these patients are, a PaO2 to FiO2 ratio less than 100 means these patients can't achieve normal oxygenation even at inspired O2 concentrations of 80 to 100%. With hypoxemia to that degree, you'll likely see cyanosis of the hands or face on physical exam. On pulmonary auscultation, listen for diffuse crackles, which is reflective of all that fluid filling the alveoli. At Sketchy, crackles are represented by our recurring symbol, the crackly Velcro holding that life vest together. Or formerly holding it together. Kinda like our scuba diver. He just could be doing it better is all I'm saying. Like less drowning. For the most part, labs aren't required for the diagnosis of ARDS. Rather, they're used to help figure out the specific etiology. But let's begin with the exception to that rule. An ABG is critically important and necessary for the diagnosis of ARDS since that's how we measure PaO2. At Sketchy, ABGs are represented by a red syringe, like that one stuck into this roided-out animatronic shark. Man, I hate those. Okay, who shot this guy up with Skynet juice? Was it you, inappropriately chilled deep-sea diver dude? As you'd expect, patients with ARDS will have hypoxemia, defined as a PaO2 less than 75 millimeters of mercury, as well as an elevated alveolar arterial, or AA gradient, reflecting the fact that hypoxemia is caused by an intrapulmonary disease process rather than hypoventilation or reduced inspired oxygen tension. That's why we've drawn a big A and a little a into the fins of this Terminator shark. Terminator 6, the Sharkinator. My idea. I called it first. Need a refresher on the mechanisms of hypoxemia? Check out our hypoxemia DDX sketch for more details. But seriously, don't steal my idea. Last but not least, if you suspect ARDS, you'll definitely need to get some imaging. Patients with ARDS must have diffuse bilateral alveolar infiltrates consistent with pulmonary edema on chest imaging. They kind of look like all the fluffy white spots on the shark's gills. Most often, these infiltrates will be pretty apparent on a routine chest x-ray, hence a recurring skull and X-bones flag down there, but a chest CT can be done if the x-ray isn't a slam dunk. So, to summarize, the diagnosis of ARDS requires all four of the following criteria, collectively known as the Berlin definition of ARDS. First, respiratory symptoms must have begun or worsened within 1 week of a known cause of ARDS. Second, chest imaging must show diffuse bilateral opacities consistent with pulmonary edema. Third, the patient must have hypoxemia with a PaO2 to FiO2 ratio less than 300. And fourth, the patient's respiratory failure must not be fully explained by heart failure or fluid overload. Which brings us to the differential diagnosis. Since ARDS is, to some extent, a diagnosis of exclusion, you do have to do some work to rule out other potential causes of acute hypoxemic respiratory failure before you can be confident in your diagnosis. Cardiogenic pulmonary edema is virtually identical to ARDS in its presentation, which is why the Berlin definition requires exclusion of heart failure as the cause of the patient's clinical picture. That said, heart failure exacerbation has its unique findings, so search for an elevated JVP, S3 gallop, elevated BNP, or echocardiography findings to distinguish cardiogenic pulmonary edema from ARDS. For more details on the clinical presentation of heart failure exacerbation, check out our sketch dedicated to it in the cardiology unit. Beyond cardiogenic pulmonary edema, the other major diseases on the differential include an acute exacerbation of an interstitial lung disease or another alveolar filling disease like diffuse alveolar hemorrhage. A past medical history positive for interstitial lung disease, as well as unique chest imaging findings such as reticular, nodular, or reticulonodular opacities suggest that interstitial lung disease may be the culprit. While you might think that diffuse alveolar hemorrhage would be pretty easy to identify, not everyone who has it presents with hemoptysis, especially if they're already intubated. However, if you go looking for blood, you'll find it. A bronchoscopy will typically show frothy, bloody secretions and large amounts of red blood cells on bronchoalveolar lavage, which distinguishes diffuse alveolar hemorrhage from the pulmonary edema of ARDS. Let's summarize the classic presentation of ARDS in a sample assessment statement. John Ards is a 40-year-old man admitted 2 days ago for acute pancreatitis who has developed new respiratory distress over the last 24 hours requiring increasing levels of supplemental O2. His exam is notable for tachypnea, oxygen saturation of 89% on 100%, non-rebreather mask, confusion, substernal retractions, and bilateral inspiratory crackles on auscultation, all of which are new compared to his exam on admission. He does not have elevated JVP or pitting extremity edema. Chest X-ray shows bilateral opacities throughout the lung fields. This patient's new symptoms are concerning for impending respiratory failure from ARDS secondary to his acute pancreatitis. Well, don't just sit there. Your patient has ARDS. Do something. As we mentioned earlier, virtually every patient with ARDS has respiratory failure requiring intubation and mechanical ventilation. If you've caught ARDS early, congrats. More likely than not, you'll have to mechanically ventilate them sooner or later, so you best prepare for it now. Fortunately, there's been a lot of research done on the management of ARDS. The lessons we've learned drive what's now called lung protective ventilation strategies for ARDS, which include low tidal volumes, maximizing PEEP, and minimizing FiO2. These strategies are designed to maintain adequate oxygenation and ventilation while minimizing ventilator-induced lung injury. Need a refresher on the basics of mechanical ventilation? Check out our ventilation and oxygenation support how-to sketch for more details. First things first, get to low tidal volumes. Low tidal volume ventilation is the cornerstone of the lung protective strategy. Makes sense, right? You don't want to be blowing up already fragile and full alveoli with tons of air. They'll explode. Smaller tidal volumes are less likely to generate alveolar overdistension, which is a major cause of ventilator-induced lung injury. Early use of low tidal volume ventilation improves mortality in ARDS. So how low is low? In general, aim for a tidal volume of 6 milliliters per kilogram of ideal body weight, which is calculated as 50 kilos for a man or 45.5 kilos for a woman, plus 2.3 kilograms for every inch taller than 5 feet your patient is. Don't worry, you won't be required to calculate ideal body weight on the test. What happens if you don't use low tidal volumes? Well, higher tidal volumes generate higher peak airway pressures. In ARDS, where lung compliance is already low from atelectasis and pulmonary edema, even a small increase in tidal volume can produce a huge increase in airway pressures. High airway pressure can cause barotrauma and lead to pneumothorax when it overwhelms fragile alveoli and causes them to burst. At Sketchy, pneumothorax is represented by a collapsed sail, just like the one on that sunken sailboat. Another tour group bites the dust. And that's why we use low tidal volumes. The second pillar of a lung protective ventilation strategy is cranking up the positive end expiratory pressure, aka PEEP. PEEP helps open up the collapsed alveoli and keep them open, allowing them to participate in gas exchange. Increasing PEEP is one of the best ways to improve oxygenation in a patient with ARDS. Don't just stand there and peep what's happening, guy. Do something. Never mind. I'd be doing the same thing if I were you. That said, too high of a PEEP has its own downsides, namely high plateau airway pressures. That's why the goal is to maximize PEEP while keeping airway pressures in a safe range to prevent barotrauma. Most of the time, just increasing the PEEP isn't going to get your ARDS patient's oxygen levels up to snuff. The other way to improve oxygenation is, well, increase the FiO2. Bubbles for everyone. Whoa. Hold your horses there, Haas. Before you crank the oxygen all the way to 100, remember that too much oxygen is a bad thing for the lungs. Therefore, aim to keep your patient's PaO2 levels between 60 and 80 millimeters of mercury, which roughly correlates to an O2 sat between 88 and 95%. To help you remember these PaO2 goals, check out those bubbles leaking out from that red artery like tubing. Looks suspiciously like a 60 and 80, don't they? Anywho, once you've achieved that oxygenation goal, turn down that FiO2 as soon as possible. See those bubbles emanating from that O2 tank? High FiO2 damages the lungs by promoting the formation of oxygen-free radicals. This is known as oxygen toxicity, and it usually occurs at FiO2s greater than 60%. Let's wrap up this sketch with a brief summary of what we've learned. ARDS is a clinical syndrome that's caused by inflammatory damage to the lungs, which leads to increased pulmonary capillary permeability and subsequent fluid leakage, resulting in pulmonary edema. The classic presentation of ARDS is in a patient hospitalized with a known inciting event who subsequently develops acute progressive dyspnea and respiratory failure requiring intubation. Importantly, ARDS symptoms must develop within 1 week of an inciting event, or else it's not ARDS. What are these inciting events you speak of? Well, sepsis is the most common cause of ARDS, but some other important ones include trauma, aspiration, pneumonia, pancreatitis, and blood transfusions. On exam, the most notable feature of ARDS is hypoxemia that's poorly responsive to supplemental oxygen therapy. Refractory hypoxemia is often the impetus for intubation and mechanical ventilation in patients with ARDS. A chest X-ray will show diffuse bilateral pulmonary edema and is required for diagnosis. Speaking of which, to make the diagnosis of ARDS, we turn to the Berlin definition, which stipulates ARDS symptoms must have begun or worsened within 1 week of a known cause. Bilateral pulmonary opacities consistent with pulmonary edema must be seen on chest imaging, and the patient's respiratory failure cannot be fully explained by heart failure or fluid overload. To determine the severity of ARDS, we use the PaO2 to FiO2 ratio. Mild ARDS is defined as a PaO2 to FiO2 ratio less than 300, moderate less than 200, and severe less than 100. Once you've made the diagnosis of ARDS, the main treatment is a lung protective ventilation strategy, which includes low tidal volumes, high PEEP, and minimization of FiO2. The goal tidal volume should be 6 millimeters per kilogram of ideal body weight. To achieve adequate oxygenation, crank up the PEEP. High PEEP, to an extent, allows you to keep those alveoli open and improve gas exchange. You'll have to increase the FiO2 to achieve a PaO2 goal of 60 to 80 millimeters of mercury, but as soon as you can do so, titrate down the FiO2 below 60% to minimize the risk of oxygen toxicity. These strategies are only meant to support your patient. In order for them to get better, you'll have to treat the underlying cause of the ARDS. Thanks for watching. We've talked a lot about mechanical ventilation concepts in this sketch, so if your head's spinning, fear not. Head on over to our ventilation and oxygenation how-to sketch for a refresher. And check us out next time when we'll dive into the world of lung cancer.